Good afternoon, David. Thank you so much for taking some time out of your busy schedule to be on the Meaning Project podcast. How you doing today?
Thank you, Dan. I'm doing well. Hope you're good as well.
Absolutely. It's been it's interesting. I feel like this podcast may be going into, me doing a little bit of my personal therapy with you as the mental health services director at Michigan Department of Corrections. My day's been full of some of that kind of work, and interestingly, when we get done here, I get to go lead a therapeutic group for men with substance abuse issues. So
Excellent.
yeah, a lot of I see our worlds definitely intersecting, but talk a little bit about, what is your job? What does it mean to be in that role in the Department of Corrections in Michigan?
Okay, sure. I always feel like I first have to say I'm not officially representing the department here today, but this is my regular job and what has informed everything that I know about working with people that are involved in the justice system. And so my role means that I oversee all of the treatment that we do for people that have been incarcerated into the State Department of Corrections in Michigan. And right now that stands just a little over 11,000 individuals. Most of those are men, but about 10% of those are women. And our female population for those that engage in mental health treatment is much higher than with the men. I'd say it's over 50% now. Men are hovering closer to about a third of the population. In Michigan, we also incorporate treatment that we do for people that have committed sex offenses under that umbrella. And so we have licensed professionals doing that work as well as the mental health treatment work. And then we also have another arm that reports to me who do substance use disorder treatment. And that involves some work both in prison and for parolees. I should say both the treatment of individuals with sex offenses and with substance use disorders have both inside prison and parolee work that we do. And
Wow.
so
And you're responsible for coordinating treatment for, now this is voluntary treatment, right? Nobody's coerced into treatment or treatment resistant. These are people that volunteer for services, or are they referred to these different services?
all of the above, actually.
Okay.
So we certainly offer anyone that is showing signs of a mental health disorder an opportunity to engage in treatment. But as you might imagine, we get some very sick people that haven't been treated out in the community, and they engage in some kind of criminal behavior. They end up in prison and they don't want to engage in treatment. They believe that they're just fine, and they're clearly not. So we do have a process, which I think most states do. They can vary pretty widely, but ours, we are able to treat prisoners involuntarily and ensure that they get treatment, because we don't want anybody just languishing in prison. If you're in the community, you certainly have the right to go and be mentally ill if you're not bothering anybody, but that brings up all kinds of other issues when you have custody of somebody, to just let them kind of languish in that mental illness, if that puts a good picture on it.
That makes complete sense, but I am curious, as in my early career, I was fortunate enough, cursed enough, I don't know what you would say, to work with with juvenile delinquents who were court ordered to treatment. And I'll tell you, it is not easy to have a conversation with somebody that does not want to have a conversation with you, especially when it's about their choices, their behavior, and how to do better or differently. How does that work for you in the state of Michigan with prisoners like that?
I would say very much the same.
Okay.
And we don't frequently have people that are at their most insightful point in their lives on kind of the greater part of the whole, I would say that. And so they're interested in issues that might speak more to where they're having to lock, at what particular prison they're locked up at, what's going on with we call them their bunkies in Michigan, their roommates, what's going on with programming that they want related to getting a parole and all kinds of things like that. But that also, as you know, having worked with people that have some leverage
Hmm.
associated with their care, that you can
Hmm.
use that to engage them too. And
Absolutely.
you definitely see people that start to engage, start to learn more, learn coping skills, get medicine if they need it to manage their mental health disorder,
Hmm.
and do things very similarly. But it is a population that is a captive audience.
Right. I would guess the opportunity for motivational interviewing definitely comes into play a lot there.
It does. Our entire department is getting trained in motivational interviewing, which is fantastic
Wow.
because everybody inside of a prison interacts with all of those prisoners. And
Yeah. Yeah. For you casual listeners out there, motivational interviewing is definitely a treatment technique and modality that you can learn more about, or move to Michigan and get trained by David and his staff. I am curious, how for 11,000 prisoners, how big is your staff?
I have in total a staff of around 400 that includes support staff and clinicians. I believe the number is somewhere around 280 clinical staff that are licensed, either social workers, counselors, or psychologists. Michigan is one of the few states where you can actually work as a psychologist with a master's degree and a limited license. In many other states, you have to be a doctoral level,
Right.
fully licensed psychologist. So we're able to use that to good effect
Uh,
here.
yeah, and I'm curious. In most states, a psychologist, the primary role of a psychologist is assessments and diagnostics, where the master's level provide treatment and psychotherapy. Is that true for you and your department?
Yes, and we do have special positions for psychologists that it doesn't matter which level they're practicing at,
Hmm.
but if they have the training to be a psychologist and they can get a little bit better pay, then we want them doing assessments, testing, helping inform differential diagnostics, things
Makes
like
sense.
that.
And now, I mean, when I think of a director or a supervisor for clinicians, right, what that generally means is you're meeting with your supervisees and talking about cases and spending time making sure treatment is going well. There's no way you're doing that for 400 people on a regular basis. So, what is the nature of your job?
Well, I'm a bureaucrat,
Congratulations.
governmental organization. But we do have that kind of pyramidal structure. And so I've got managers that report to me, and then there are
Mhm.
direct supervisors that work daily with those clinicians. And so there are vast differences in the teams. And one team may be composed of a supervisor, two clinicians, and a secretary. And there's another one that's more like 20 people
Mhm.
operating and doing different things, and it just depends on what's needed at that given facility. But it's those line level supervisors that we require to do that clinical supervision. And then I tend to handle more policy related issues.
Mhm.
Sometimes there are issues about transfers to a different level of care. We do have a full continuum of care within the
Mhm.
department. So outpatient treatment, acute care, everything in between. And um, sometimes have to make clinical decisions, but those are
Mhm.
usually difficult things that have come up and people are arguing about it, or
Mhm.
some higher level decision needs to be made.
So, how were you lucky enough to move from clinician to bureaucrat so quickly in life?
Well, in some parts it did go quickly, in other parts not.
Hmm.
And I am fond of saying that the department has been a journey for me that was kind of like getting dragged kicking and screaming much of the way. It was not where I ever thought that I would end up being.
Hmm.
I had applied for a job with the state that I thought would be something entirely different, and wasn't expecting a call for an interview with the Department of Corrections. Almost didn't go for the interview, but I went and it seemed interesting and it paid better than what I was getting at the time. And I quickly found out that it did seem to be a good fit. It's very interesting work because you get to see a whole scope of and everything that you can possibly imagine, because people that end up in prison are not our healthiest, either physically or mentally in any way. And so we get an opportunity to see that, experience it, and help them quite a bit.
Mhm.
And so back to the journey, I quickly realized that there were some good opportunities to advance that I hadn't seen quite so clearly in my previous work, which actually was with adolescents. I've seen a couple of my former
Ooh.
clients come into the prison system, and it wasn't particularly surprising with them, but sad. And uh, and then you just kind of see those opportunities come along, and as you become vocal and passionate about what you're doing, and are mentored along the way. I've had great opportunities to be mentored and coached into this kind of a role, and of course there's a ton of support in a large organization like this. There are very different kind of CEOs of behavioral health organization roles that I think are much more lone wolf than what it looks like for me, even though it's a huge job.
Yeah, yeah, definitely a huge job. And to that idea of passionate about it, I know in our other meetings we get to participate in that passion definitely comes through in your desire to help those people under your care. Being on the other side of your southern border, right? I am in the state of Indiana, close to Michigan. One of the things as a clinician in that role on my day-to-day work, um, is that I deal with people that enjoy going to Michigan for your legal marijuana and then illegally
Oh, you haven't done
bring.
that in Indiana?
We have not. And it's fascinating. I believe Indiana is surrounded on all four sides by states with legal marijuana.
Okay.
And I'm just curious, being that that's something I deal with, I mean, nearly daily if I'm in the office, what has that done in the state of Michigan, the legalization of marijuana?
I think we still have yet to see the full impact. We have some folks that are still very much working on that were against the legislation, that are working on the prevention side now and trying to highlight the issues with it, especially for kids. I think
Hmm.
that's where our primary concern is.
Hmm.
It's really tough because when we legalized it in Michigan, I'm trying to remember exactly when that was. I think it was during the height of the pandemic, actually.
It hasn't been that long. I think you might be right. Yeah.
And and so that certainly has put a twist and a fog on the outcomes of that, because in the justice system, it became very difficult to move prisoners. And you've got people in carceral settings or in combined living situations, whether it's a nursing home or a group home or whatever that is. You really have to be very careful about COVID, of course. And so sometimes the whole jail will get locked down. We have prisons that get put on a quarantine status.
Hmm.
And so that has changed the dynamic of people entering jail and prison as far as the numbers go. And so we saw a decline at first, and then this year I think there's been an uptick. But even the courts are behind
Hmm.
on
Sure.
getting people processed and sentenced and all of those things. So I think we're gonna be gathering that data for quite some time. Um, as far as marijuana goes, that's the least of our problems
Hmm.
with fentanyl. The drugs are so in such minute amounts and so easy to take anywhere you want to go that we're experiencing problems across the state, in prisons and jails, in communities, and just like everybody is.
Yeah, I think the fentanyl problem is certainly one of the biggest ones we're facing, even in small town Indiana. Previous to my work here, I worked in Indianapolis, but also got to do some work in Detroit and would commute back and forth. And I remember that area, the triangle of Chicago, Indianapolis, and Detroit was pretty much a heroin triangle
Mm.
in our country, and it was known for significant trade. And now with fentanyl being so accessible, I mean, it's terrifying to think of it. I just heard an officer yesterday talk about a local overdose of somebody who had used pure fentanyl. hardly any heroin in it. It was just, that used to be the big taboo. Oh my goodness, one gram can, or one grain of the substance can kill you, and now people are using entire doses of it.
Yeah, it's unbelievable. So frightening because just an exposure where you breathe a little bit
Hmm.
and you're really at risk. So
Yeah. What are you seeing in your state when you say marijuana is the least of your concerns? So obviously heroin and fentanyl. Any is that the primary substance you're dealing with up there?
seems that we seem to be getting news about overdoses of the opioids.
Mhm.
Um, I'm trying to think of the name. There are some synthetic issues too. Is it K2?
Hmm.
That's fairly easy to
The gas
process.
station weed. Yeah, that's
Yeah, that's been scary. And sometimes we just don't know. I don't think we're seeing as much. I don't hear as much about cocaine.
right.
There are a lot of concerns about other stimulants like meth.
Hmm.
And the bad thing about meth is we haven't yet developed anything like Narcan or naltrexone stop an overdose like you
Yeah,
can with opiates.
that's so very true. And um, I mean, we know an opiate overdose or a fentanyl overdose can, what it does is it stalls the entire nervous system to the point that, no more breathing or no respiration or heart rate. What does a meth overdose look like? Because that meth has the opposite effect of opiates. What does that do?
I wish I could answer that question, but I am
Okay.
not the right person to ask on that one.
Yeah. And I would guess, I mean, we know the brain damaging effect. I mean, literally it's been known to eat at people's brains. So I would guess
Mhm.
an overdose could look different in different people. But really quick, back to that idea of K2, right? This stuff used to be easily accessible in your local gas station. It was right up there by the register. And I thought it was taken off the market, but it sounds like you're still seeing issues with it.
I hear about it, at least rumors, and they want, or somebody will report that that's what they used,
Hmm.
and things like that.
Yeah, just a random mix of who knows. It's like a potpourri of substances. Nobody ever really knew what was in it.
Yeah, and in a prison, if people are able to get some substances to mix up,
Mm.
sometimes they don't know what they're doing. They're not able to accurately report on what it is that they're doing, especially if they're in a compromised mental state
Sure,
or they've
sure,
used something. So sometimes we don't know, and sometimes the hospitals may not know what to test for. It's hard to keep up with
sure.
the organic makeup or the molecular makeup of those drugs.
So I am curious. One area of treatment I never really found myself going into was working with um, uh, crimes of a sexual nature, abuse, things like that. But I am curious what, you said you have a treatment program for that or trained therapists. What is that kind of work like? Who are those people treating and how effective is it?
Great question. And it wasn't an area that I specifically went into, but with the changes in our department over the last few years, we kind of merged those things together. And I really like that as a model
Hmm.
that people who are engaged in any kind of psychological, emotional, based forms of treatment, whether that's just cognitive behavioral therapy, or if it's specifically targeted toward addiction or someone with sex offense behavior, um, they work as a team and you don't have all these separations. We used to have psychologists and then the mental health treatment professionals.
Hmm.
And as you can imagine, referrals to each other would cause conflict at times. And oh, that's your patient, that's your patient. So we brought those together, and that's a much better model. And so I have those the staff treating both in most cases, somebody with a mental health disorder or with a sex offense that we want to target and treat their thinking and their behavior, or it might be a comorbid kind of a situation with both of those things going on, plus the substance use disorder. We'll
Right.
certainly see that and need to treat all those at the same time. Our staff in Michigan get pretty highly specialized training in doing risk assessment, uh, and then doing a targeted program, which can last anywhere from 6 to 9 months for individuals that we determine are at moderate to high risk of reoffending.
Mhm.
It gets, this is a topic that we could really take a deep dive into, but a really interesting term that I learned along the way was the iatrogenic effect, in that you can actually treat someone who is at low risk for recommitting a crime or for just engaging in criminal behavior in general. You put them in a group and you can make them worse. You can actually
Right.
encourage criminal behavior by putting them with other people
Mhm.
that are higher risk than they are. And so that's why we really try to separate that out. And sometimes that's really hard to get across to administrators and judges and parole boards, that we need to put all of our efforts and expenses in this group because that's our highest chance to really make a difference. And we can actually do harm if we focus on just everybody that's ever done anything sexually offensive. Because whether anybody out there likes to hear it or not, some people getting caught makes them self-correct
Mhm.
and they won't do
That
it again. And it's actually very unlikely that someone convicted of a sex offense is going to recommit sexual offending behavior. And the people that are at highest risk of recommitting are actually much lower risk than you might think. And
really.
the conventional wisdom is that they all are going to do it again and again and again. And it's simply not true. And and so we are working so that we have no more offenses is our ultimate goal. And that's why we target individuals. So that work becomes very challenging, as you can well imagine.
Mhm.
People don't want to acknowledge their behavior that is shameful and ugly. But we have a program called the Good Lives Model that we work toward. And so instead of stop doing that, you point people toward what a healthy life looks like, and
Mhm.
that actually engages them in behavior that we want to see out in our communities. And
Wow. And I mean that idea of conventional wisdom, I know even in my mind, like once you're in a sexual offender, the idea is, well, you'll continue to reoffend. But you're saying no, that's not true, at least for less severe offenses, maybe.
um, yeah, and even for some of the high risk people, I mean, you have your individuals that is their entire. I mean, we have criminals that we don't ever want to let out of prison. Most
Right.
people go to prison and do eventually get released, but there are dangerous people that have gone too far and we can't get them turned around.
Mhm.
But um, you know, I'm a little hesitant to quote statistics, but I believe it's less than 50% of recidivism, reoffending in some of the highest risk groups. That's still too high to release, but overall, if you take the whole group and look at them statistically, it's under 5%.
That's amazing. And yeah,
Recommit.
I know recidivism rates, overall are considered to be much higher. And when you have a less than 5% recidivism rate,
Yeah,
that's a
in
solid statistic.
net population, yeah.
Yeah. And
Um, and I'm sure lots of people would question that. Um,
well,
but
absolutely. I think out in the civilian world, in our world, well, why can't you get them to zero, David? Come on, we shouldn't, this
well,
should
that
never
includes
happen
the ones
again.
that are
Yeah.
zero.
Yeah.
But we look at things. This stuff has been so interesting to me because you look at um, the sex offender list when you have to report and register as a sex offender, and what that does to people is it puts extreme restrictions on where they can live, where they can go with friends, where they can go out to eat. And they
Hmm.
actually, you think about that. I've got to, before a buddy calls me and we go out for dinner, I got to check and see if it's very close to a school.
Mhm.
And that isolates people.
Mhm.
And when you and I, as psychologists, know what isolating people does to them, you're
Mhm.
going to increase anxiety, you're
Mhm.
going to increase bad behavior,
Mhm.
uh, unhealthy thinking patterns, and that's what actually leads to continued sexual or other criminal behavior. So
Mhm.
we want to engage people and get them involved in normal, healthy relationships.
Absolutely. I know that is one of my greatest frustrations. It's a necessary evil when somebody commits a driving offense while under the influence, right? A DUI, an OWI. Um, but when we take away their driver's license for a certain amount of time, that's exactly what that does is it isolates them from many people, it prevents them from productive work. And what are they going to do while they're sitting at home all day long but
Mhm.
return to substance use and abuse? I recognize, hey, we can't have those people out on the road after they've just offended or done something, some kind of vehicular crime, but there's got to be a different way.
Yeah, if that's all we do is lock them down and isolate them, then we're really not getting what we want as a society, which is improved behavior and less of that kind of criminal behavior.
Right, right. So let's go to the other direction, something that near and dear to my work, as I said, that I'll be going and leading a men's substance abuse group here in just a little while. What is the work being done in Michigan along substance abuse treatment? Are there particular programs you use an AA model, cognitive behavioral therapy? What works in your state?
Okay. So we screen everybody that comes in our front doors
Mhm.
and figure out if they have a likely substance use disorder or not. And that way it it's a system of 32,000 people in prison at any given time and about 9,000 people going out on parole, 9,000 new people coming in. So you're talking about touching the lives of 50,000 people throughout the system over the course of a year. And
Wow.
so we need to have an idea of who's coming in the doors and what they're going to need, because what we'll do is put in requirements for them to complete if they're going to meet their parole requirements for requirements. You know what I'm trying to say.
Absolutely. That
And
that checklist they have to accomplish.
yeah, and so by the time they get to the parole board, say they do a 5 to 10 year sentence, they're going to take a look at them before they get to 3 years and say, do you need some substance use disorder programming? Have you gotten your educational requirements? Because we will give everybody a GED that needs it. We require everybody to have a job. And I mean, requires maybe a strong word, but we highly encourage it. I'll put it that way.
Mhm.
And um, and there's some other opportunities, all kinds of vocational opportunities as well. And then we look at whether they need sexual abuse prevention. And of course, mental health treatment goes into that, but mental health treatment is not a requirement of
Mhm.
parole. Other programs would be. If you've got a substance use disorder, you have got to take some classes in order to be eligible for your
Mhm.
parole.
Mhm.
And so we will put them either in a shorter, more didactic oriented class if it's a less severe disorder, and we'll do a longer therapeutic class, which is cognitive behaviorally informed,
Mhm.
if they have a more severe substance use disorder.
Mhm.
And so we're talking 34 weeks or so, several months
Oh my.
of programming that they need to take in order to get out. We also, as most states are now, using some form of medication assisted treatment offered
Mhm.
to certain individuals with opiate use disorders or alcohol use
Mhm.
disorders,
Mhm.
because Vivitrol is effective, Suboxone is
Mhm.
effective,
Mhm.
and then we haven't figured out how to get methadone going mostly because of the laws around how you operate methadone clinics.
Right.
Um, and then what else didn't I say? Naltrexone.
Mhm.
I mentioned Vivitrol, but oral
Right.
naltrexone would be the other opportunity. And those present their own challenges in prison, but it's just such a high need, and putting people back on the street who haven't learned to manage their addictions can be really unsafe, as you could well imagine.
Absolutely. And I can imagine, I know part of what I teach in my substance abuse work is The finding meaning in one's life can often prevent, that is contraindicated with substance use, can often be very helpful and prevent somebody from relapsing back to previous levels or at all. But it's got to be kind of hard to do in a prison setting to say, okay, let's talk about what you might find meaningful in life. Although you did say education and career and jobs is something that you work with people to have before they're released. That's a difficult task to be called to do.
Yeah, absolutely. And
Real quick, I want to, I forgot, for the casual listener out there who is not a psychologist or working in the Department of Corrections, let's run through Suboxone, Methadone, Vivitrol, and naltrexone real quick. Vivitrol and naltrexone used for?
mainly at this time, opiate use disorders, but they
Okay.
are also effective for alcohol use disorders.
Correct. Right. Right. And that's what I found is, for many people, even prior or without incarceration, those who have found themselves in trouble or short-term time in jail and referred to community corrections, I believe it's Vivitrol, can be very helpful in diminishing cravings, and even when if they return to or try to drink, it doesn't have the same effect.
Right. And it's super interesting to learn about how those things work.
Hmm.
I'm not a physician, of course, but about how they affect the neurons and the ability of the drugs to have an impact on the brain is really interesting. And the Vivitrol, of course, we didn't mention, is the long-acting injectable form
Right.
of naltrexone. And
Right.
so that's got obvious advantages with only having to take it once a month or so.
Yep. Yep. And then Suboxone and Methadone specifically for opiate use. And if I remember correctly, those are opiate agonists that actually block the
I
opiate
think
receptors.
I'm always a little afraid to say that because I haven't learned it deeply enough to be 100% certain, but I think that's right. And they do block the ability of the drug to
Mhm.
kind of latch onto the brain and have an impact. Suboxone, I should mention because people will ask me why. Why do we have to do this? Because Suboxone strips get sold on the street as a drug.
Mhm.
I think it's
Mhm.
mostly a kind of imagined effect, placebo effect, but they are worth something in carceral settings and on the street. Um, but they are the only approved medication that is evidence based
Mhm.
to reduce overdose deaths
Right. Right.
amongst any effort.
Where, and if I remember correctly, methadone is not an agonist. It's a replacement therapy that
Mhm.
just kind of keeps people. It's a harm reduction method where
Yeah.
they get a little bit and they have to take that daily. And most, I know in the state of Indiana, it is hard to do because they have to go to a facility at 5 o'clock in the morning to get their daily dose of methadone because they're not allowed to have more than one dose at a time.
Mm-hmm.
Yeah,
Correct.
interesting. What I know by day you're the director of mental health services for this Michigan State Corrections. By night you put on your cape and your mask and go about speaking to audiences about these topics. What are you speaking on lately, and where might people be able to catch you?
Oh, thank you. So I'll back that up just a little bit because
Sure.
it was definitely in my work in the justice system that got me informed about trauma in
Mm,
the population of people that get involved in the justice system. And I was fascinated by it because when I was in school, that wasn't something we were talking about back in the early 90s.
mhm,
And what studies have been able to find, like by looking at people who end up in mental health diversion courts or drug courts and things like that, is nearly 100% of them have experienced lifetime trauma. And oftentimes we're coming into the court currently in a trauma situation. You think about sex trafficking or drug trafficking, things like that, where they're being forced, used, different kinds of situations, beaten, whatever that might be.
mhm,
And so I learned about adverse childhood experiences and
mhm,
trauma and got really passionate about continuing to learn about it and telling others because it really felt like a missing piece for me why do so many people end up in the American prison and jail system and we don't get them out and make them better, is that we haven't really learned to address the trauma that they're facing. And most correctional institutions have not learned to become trauma informed, where you simply change your policies and practices to expect that everybody in your organization is probably a trauma survivor, including many of your staff, and that you learn to respect and include some of their choices, and that you identify trauma and trauma responses when you see it. So that's my background where I came to this. And so I have put together workshops and keynote addresses to simply talk about and educate people about the fact that we have people in our justice system that are 100% trauma survivors.
Mm-hmm.
And if we address that issue, I really think we can start to get to the point where we can address their criminal or criminogenic behavior. If you're a research-oriented person, that term gets thrown around. And that it can change. I think a lot of people believe that criminals start this behavior and you can't get them off of that track. And it's really simply not true. Like I was talking about earlier regarding sex offenses, that's true with other behaviors as well. If we address it and treat it, we can put people on a different path.
Mm-hmm.
And I've got some stories I can tell to illustrate that, as well as the statistics.
Sure. And I think that's amazing. Like as a clinician, I've begun to recognize this in the past 5 to 10 years, because the data is coming out there and it's just overwhelming that not just offenders, but most of us, most human beings have experienced some form of trauma in their life, and maybe don't even recognize it, but certainly the prison population has. It's ironic to me when I do a lesson on trauma in my men's substance abuse group, generally waiting for most of these gentlemen to be comfortable with me and the group and everything. It's amazing. I would agree with you. Nearly 100% of them say, wow, yeah, holy cow, this is what happened to me. And now I can understand why I used and why my use increased and why I was never able to stop, because, I was avoiding all of that past hurt or frustration or whatever it might be. And when you get through that and heal the trauma, there often isn't a need to go back.
It's amazing, isn't it?
It is.
Yeah.
I mean, I think it's a sad statement about, human affairs right now, but I'm sure it's not unique to our times, but we are fortunate enough to be realizing it and being asked to do something about it.
Mm-hmm. Mm-hmm.
So can you share a success story and maybe some statistics with us? Send the listeners out with the positive.
Yeah, my favorite story, I've got lots of statistics and lots of things I could talk about, but my favorite story, I'll just go to that, is a woman that we work with professionally now, who gave me permission to tell her story. And she, as a child, had been given up for foster care. It was one of those situations, you may hear about these, where the child is taken out of the home, the parents will take a class or something, the child goes back, but then they're punished for whatever happened, and the child kind of takes the brunt of the anger about the shame that the parents experience by having their child taken away. And back and forth, back and forth. And this girl, Deb, finally meets a guy, it's a crazy story, at the circus. And she that had come to town, and she decided that she was going to run away. And she laughs as she says this, with the bearded lady and the stretch guy. And she ends up in a hotel room with a kitten and a beer. And what do you think happens next? Of course, she becomes sex trafficked and gets involved in drugs, drug trade, and over time has kids of her own, but ends up in prison and, of course, loses her kids. And Deb does a couple of years, paroles out, violates, comes back, and she sees a a class. We'll do groups and volunteers will come in, and some women presented and talked about their lives, and they were serving life sentences. This was a group of women serving life in prison. And she, there's one of those moments, the light bulb comes on, and she realized their lives are just like mine. I could be serving that life sentence if one thing had gone the other way, or if I'd gotten caught doing this and I didn't get caught. And she started taking classes, wanted to get her kids back. That was a big motivation. And she learned about what the trauma meant. You know, somebody gave her the ACEs checklist, and it'd be great to talk more about that. But there's 10 items. You can look up the adverse childhood experiences if you're not familiar with that, anybody listening. And it's led to fascinating developments in our understanding of what happens to people in their health and mental health when they've gone through trauma. And Deb now is one of our trainers for peer recovery coaches and peer support specialists who have lived experience as a person with a substance use disorder or addiction or a mental health disorder. And she's teaching prisoners how to become a peer mentor to other people in the same situation, and just making a tremendous difference in doing that. And it's such a happy story. And she works so hard helping develop other people that have similar stories to her. And she goes and talks to groups of men inside prison, and they just eat it up.
Wow.
But, you know, she can say, I'm like you. They see that, and it's an inspiration for them. So that's been one of our happy stories that's happened, and we get to see it on an ongoing basis.
That is that's amazing, and I can tell you, I'll share with you and the listeners. I'm having a significant reaction to that, because ironically, just this week, I think the individual I'm dealing with is in the middle of that stage, foster care, which, you know, that's no fault of the child. You know, that most children wind up in foster care because their parents are making poor decisions, illegal decisions. Ran away from foster care, found the sex industry, and found it's profitable and enjoyable, and of course traumatic, but sometimes profit reigns over trauma, and that's really a hard one um to change, right? Because it's really hard to encourage somebody to go to college and work for or just go get a job and work for, you know, $20 an hour, $10 an hour, when they say, I can make a phone call and make $300 to $600 right now.
Right.
So my hope for that individual is that that we get through this idea of, you know, but look at what it's doing to relationships, look at how it continues to re-traumatize you, and look at what a guiding light you can be to others, so that they don't have to experience what you have experienced. So I certainly appreciate that that happy ending story.
Well, I hope they see that light as well, and that the leverage is effective.
Well, and I think your story certainly proves that, you know, for those of you out there that believe people in the criminal justice system cannot be reformed or cannot, you know, start a new life, I mean, that's an example right there. At some point, it does become a choice, but it also becomes good fate and good fortune and good people like you to provide these services and encourage others to do that. So, are you currently, for people that want to find out more, are you I know you're pretty darn busy in your day job. Are you out there in the public offering speaking services or any kind of coaching in this?
I am, and my website is jdaviddawdy.com, just the initial J.
Hmm.
My my first name is John, but I go by my middle name, one of those deals.
Of course.
So it's just so I wouldn't get mixed up with my dad, you know. But jdaviddawdy.com, and there's an email address there.
Mhm.
I've given workshops at behavioral health and addictions related conferences, and people are always really interested to talk about corrections or criminal justice, because
Mhm.
corrections is kind of a black box. So you don't know what's going on inside
Mhm.
there. And a lot of times there's not a lot of good reporting about what's happening, but we are doing good things. I wanted to say, when we're talking about good outcomes, we do good things with people serving life sentences as well. We need, and people do find meaning. And I really find that that's important, because there are reasons that we can't have certain individuals back in society, but the way we're structured, we need to make a livable life for everybody.
Absolutely. And as my favorite mentor, Dr. Viktor Frankl, says, life has meaning under all circumstances, even the most miserable. And prison life sentences can be pretty dang miserable, but there is still is the opportunity to find meaning. I know a lot of individuals I've talked to who have been incarcerated or had, long-term prison sentences have actually found Dr. Frankel's book, Man's Search for Meaning, and said, wow, it really gave me new perspective. Or for others, it really changes life for me.
That's a great circle back around. I know that's your passion, and
Absolutely.
that was a great connection.
Yeah. Well, David, thank you so much for your time. Thank you for all the good work you're doing up there in the state of Michigan. Hopefully sometime we have a chance to meet on the border and say hello to each other. And for those who are interested in your work and want to find out more, I definitely recommend finding out more about the adverse childhood experiences, the ACE assessment, and that's impact. And to find out more about you, we'll certainly put your website in the show notes. And I look forward to the next time we get to chat, my friend.
Me too. Really appreciate it.
All
Thanks.
right, take care.